Hello, everybody. Welcome back to the Incubator Podcast. We are back today for an episode of Journal Club. Daphna, good morning. How are you?
Good morning. Good morning. I'm doing really well. I'm really looking forward to. I like my set of articles, but I'm really looking forward to your set of articles.
Uh, yes, I too am looking for. Can you speak closer to the mic? I couldn't
You
hear you
got
there.
it, buddy.
Yeah, no, thank
I'm
you.
too
And then
quiet today.
what?
That's not something you usually complain about. That I'm too quiet.
Maybe I had a long night, so I don't know. Maybe my hearing is a little bit
Maybe.
dampened. Um,
Was that better?
so No, I mean it's a very interesting set of articles. A lot has come out, and
Hmm.
it's been one episode that we've been looking forward to both record and release. So we're gonna get into this momentarily. I wanted to maybe do a few announcements, if it's okay with you.
Please
Um,
do.
the first one is that obviously, as you know, May is now past, and we usually celebrate our sort of podcast anniversary when it comes to May 4th. So we had this giveaway that people could enter to win all sorts of prizes. There's a laptop computer this year, some headphones and incubator swag and all sorts of stuff. So the way to enter is very straightforward. We have a form on our website. It takes literally 3 minutes to fill out. It's a survey. It gives us some insights into what the community thinks about the podcast, what we could do to improve, topics that we could cover. So it really helps us and it helps you because it's a very straightforward way of entering the giveaway. So usually we'd like to give people notice because we are procrastinators as well. So this week will be the last week to enter the giveaway, and we will be closing the form in a week. So Sunday, June 15th, I believe, you'll no longer be able to do it. So you have until the 14th, until Saturday night, and then that's it. And if you still miss the deadline, there will be next year.
That's right. We love giving stuff away.
Yeah, yeah. Um, the other thing that I wanted to mention is that we do have some fan mail to go over. Some people have left some fan mail. I think I want to make sure to remind people that when you do send fan mail through the website, this is not something that we're running. It's something that our podcast hosting website does. We can't respond to you unless it's on air. So
Hmm.
so I hope people listen. One of the persons says, "Can you send me the link to the article from Michelle Kelly's episode, which is the guest that we had last week?"
Hmm.
All the links to all the articles are always included in the episode webpage on our website, the-incubator.org. So go check it out over there, and the articles will be listed there. Um, yeah, so the links are both there. You can access them. So I hope that answers your question. Um, we want to remind people of the upcoming Delphi conference, which is ramping up. We're going to be very excited to release the names of the speakers, some of the topics. I think now is the time to secure your slot for the conference. Again, there's limited seating. We're not one of those conferences that says there's limited seatings and the limitation is 6,000 people. We really try to keep this conference cozy so that it's intimate and people have a chance to connect with others and speakers. So there's about 200 spots, and we fill up. So if you want to secure your seat, then do so. You can go to delphiconference.org, or you can go on our website, the-incubator.org/delphi. Um, Location will be the same this year. We're very excited about giving you more details in the weeks to come. We may even have like a special video recording released by Daphna and I soon.
Sounds fun.
All right. And then the other thing that I wanted to mention is that today I wanted to give some props to somebody that reached out to us on LinkedIn, Paige Pedroli. She's been working on a book called The Welcome to the Nick Zoo. Um, Paige has some experience with the NICU and has created this book basically to help families explain a little bit what is going on when the sibling is in the NICU. The book is absolutely beautiful, and I highly recommend it. She gave us this copy for free. Such a cool perk of having the podcast, I guess. And it's really good. So I just wanted to make sure that we highlighted her work. Um, I have asked her for some additional information that I could share. Basically, the Welcome to the NICU is a dual-purpose children's book. It's great for parents to read to an older sibling ages 0 to 5. It helps explain the purpose of a NICU in a very simple and kid-friendly way. It's a high-quality picture board book with bright and colorful illustration. The book is also a wonderful resource for hospitals to give their NICU families while in the NICU. Reading to your baby has so many benefits for parents and babies, including bonding, stress relief, and early brain development. You can purchase the book on the website www.nic.zoo book.com, and then you can use the code NICZOO25 to get 25% discount code. And for hospitals and NICU workers that would be interested in purchasing bulk orders for family libraries in the NICU, you can reach out to niczoobook@gmail.com, or you can message a page on Instagram at NICU_children's book. A great initiative, a great book. So check it out.
Love that.
All right. I think that's all the announcements that I had for today, Daphna. See you next week. No.
Yeah, right. We filled the hour. No, you promised us some
Absolutely.
contentious topics.
Yeah, today we're going to talk about the PDA. And I think that there's a few articles that we wanted to review. I think the most important one, obviously, is the article that was published a couple of weeks ago in Pediatrics. And this is a report from the American Academy of Pediatrics and coming to us from the Committee of the Fetus and the Newborn. And so I think it's a very interesting article. Obviously, the background is that despite decades of research, there's lots of research that's been published on this subject that involves thousands of infants. There's still so much uncertainty around PDA management. Actually, I realizing now that I did not even tell you the title of the article, but basically it's called Patent Ductus Arteriosus in Preterm Infants. And there's so much variation. And so the goal of the article, it's structured really like a report. So it's not a study, it's not a meta-analysis, but it does go through specific topics and tends to do a good review of the literature on each subject. I think that if you are a trainee, it's a great paper to review. There's so much stuff that's been published on the PDA that it's very easy when you go on PubMed and do a search to be lost in the weeds of like which paper is the one I should be reading. So I think that the AP with this paper has done a very good job at sort of highlighting the studies that have truly impact and that need to be taken into account as we make recommendations. And obviously, so I'll go over some of that review, and then we'll go over at the end the recommendations from the AAP when it comes to the PDA. So let's start with some of the scope of the problem. So we know that for term infants, the expectation, I mean, I guess term infants do set the expectation, 90% of patent ductuses close by 48 hours of life, and nearly all of them have a closed duct by 96 hours of life. And obviously, as we get into prematurity, this story is dramatically different, especially as we go into more immature gestational ages. So at 30 to 37 weeks, basically 10% remain open at 4 days. When you're talking about babies 25 to 28 weeks, 80% remain open at 4 days. And at 24-week gestation, 90% remain open at 4 days. The spontaneous closure rate is also very different. So 73% of infants born at 28 weeks will have spontaneous closure. 94% of infants with birth weight over 1,000 grams will also have spontaneous closure. I think that what is interesting about the various closure rates is obviously the timing of things. So by day 7 after birth, the rates of closure rate decline to 2%, 65%, and 87% based on whether the duct will be remaining open for babies born 30 to 37, 25 to 28 weeks, and 24 weeks of gestation. So the conservative management reality is that 50% of infants discharged home with a persistent PDA will see that PDA close within a span of 9 months. And we know that 80% of infants discharged with a patent PDA will have closure by 2 years. And I think that that is always the challenge, because we have this understanding that we know the PDA will eventually close, but do we have 2 years that we can wait to see this happen and not suffer the negative effects of the PDA until then? So then comes all this. All these issues about treatment and so on. So I think that the first step to address is the prophylactic treatment. The big question that the paper addresses, obviously, is what kind of PDA will need treatment. So that's why I want to start with prophylaxis. So there's obviously three medications: indomethacin, ibuprofen, and acetaminophen. Indomethacin, basically the review of the data is based on 19 trials, including about 2,872 infants. And what it's been shown is that it does reduce the incidence of symptomatic PDA and reduces severe IVH. But it's been shown not to have a significant effect on mortality. It's not having a significant effect on the development of BPD or neurodevelopmental outcome. And there are concerns in the use of indomethacin with intestinal complications. When it comes to prophylactic ibuprofen, there's about 9 trials that have looked at this. There's about 1,000 infants, and it does reduce the incidence of patent ductus arteriosus by day 3 to 4, and it does reduce the need for rescue treatment. However, there's some significant concern with the use of ibuprofen, including the increased risk of oliguria, and again, no effect on mortality or BPD. Again, I know some people might be thinking, like, what about some of the other trials? Well, we're talking about prophylactic, meaning not even trying, just giving it wholesale to everybody. That's sort of what we're talking about right now. And lastly, we have prophylactic acetaminophen that has been looked at in about 27 studies, including about 2,278 infants. And while it is more effective than placebo, it hasn't really been shown to influence mortality. And so there's level of evidence 1A, which is kind of one of the higher level of evidence that we can get, that shows that taking all this into account, all prophylactic agents can close the PDA, but provide no meaningful clinical benefit that actually would make it so that we can actually recommend use. And so that's the discussion on prophylactic treatment. Now, in terms of the evidence for early treatment of the PDA, I think that the big question that everybody has is, we want to treat the PDA, and we think it's a very compelling thing to do. But the secondary question is, are we dealing with just any PDA, or are we dealing with what's known as a hemodynamically significant PDA? And the AAP does mention that to date, an accurate and precise definition of a hemodynamically significant PDA remains elusive. And the hemodynamic effects of a large left to right shunt associated with the PDA may be evident by physical examination, echocardiography, or serum biomarkers. Now, I think that one of the big things that this paper does is that it ventures a definition of a hemodynamically significant PDA. And I think that hopefully maybe that can set the standard of what should be considered a hemodynamically significant PDA, and that further research will actually use that as a benchmark to assess babies equally. Now, neonatal echocardiography has a critical role to play for PDA diagnosis and evaluation of therapeutic response, and defining a hemodynamically significant PDA involves careful determination of the PDA shunt assessment and its impact on the systemic and pulmonary circulation. It involves, number 2, myocardial and mitral valve function evaluation, especially in the context of potential for myocardial ischemia, secondary to impaired coronary artery perfusion. And number 3, clinically relevant characteristic that modify the effects of a shunt that it may have to an already compromised milieu. So, echocardiography and color Doppler ultrasonography can be used to assess the hemodynamically significant PDA on end organ perfusion and function. And they have a very, very nice figure where basically they break down the effects of a PDA into 4. We have the shunt size, the volume overload, pulmonary overflow, and systemic hypoperfusion. and basically showing you how on echocardiography we can assess these various aspects of the PDA using specific measurements. So obviously the shunt size is measured by the diameter of the PDA on echo and the flow pattern through the PDA. In terms of volume overload, that could be assessed using the left atrium to aortic ratio, the LA to AO ratio, or the left ventricular output. In terms of pulmonary overflow, we can use the same things as volume overload, but also include a left pulmonary artery end diastolic velocity in the left pulmonary artery, the LPA. And for systemic hypoperfusion, we can look at organ flow, we can look at the descending aorta and flow through the descending aorta. So I think it's kind of nice to basically understand why all these measurements are being done, because sometimes it's like, well, but why are we measuring this one and not that one? I think that summarizes it pretty well. Now, in terms of understanding the definition, I think I'm going to go straight to this table, which is basically the table 1 in the paper is a suggested definition of a hemodynamically significant PDA. And basically you have 2 criteria. You have clinical criteria and you have echocardiographic criteria. So, and you're going to have criteria from both domain in order to diagnose a hemodynamically significant PDA. So from a clinical standpoint, you should be fulfilling 2 of 4 potential criteria. And those 4 criteria are you're on high CPAP or NIMV with a high FiO2, or you are on moderate or high ventilator setting at any FiO2. So I would say that if you're a baby on an oscillator at 50%, you feel that criteria pretty well. Another clinical criteria is the presence of hypotension needing vasopressor. A third criteria is the persistence of oliguria or renal dysfunction, probably related to poor kidney perfusion. And number 4, it's abdominal distension, feeding intolerance, poor growth, neck, something like that. So any 2 of these 4 will fulfill the clinical criteria. And then you will need to have, in addition to this, an echocardiographic criteria, which will need to, at least one of these criteria need to be filled out of 4 again. These criteria are 1, a minimum PDA size of 1.5 millimeter. 2, an unrestrictive left to right transductal flow. Number 3, a left-sided volume overload. And number 4, decreased, absent, or reversed end diastolic flow in the abdominal descending aorta. If you have any one of these 4, you have met your echocardiographic criteria. So I think that this is very interesting, and I think that it's been talked about. It's probably consistent with a lot of data that's out there, but I think it's the first time we actually have the table and you can refer to it. And this is what we need to potentially maybe abide by.
Mhm. I mean, I think that was always the debate. Are people using different criteria? So
Mhm.
at least if we can decide on a standard, then we can go from there. So this
Absolutely.
is useful.
Absolutely. And so, in terms of then early treatment, I think in terms of the evidence and the risk for treatment, I think that the main sort of source of data that they're following is a recent overview of 16 Cochrane systemic reviews that combine data from 138 randomized clinical trial and about almost 12,000 preterm infants. And so when we're talking about specifically pharmacologic therapy for symptomatic PDA, what they are mentioning is that overall, all available prostaglandin inhibitor drugs are very effective in symptomatic PDA closure compared with no therapy. And the evidence there is quite high. It's level 1A. Ibuprofen used IV at a standard dose of like 10 mg per kilo for 2 doses, followed by 5 mg per kilo at 24 interval for the remainder of the course, may be preferred as it is as effective as indomethacin for PDA closure and has significantly better safety profile than indomethacin with lower risk of neck and a trend toward less intestinal perforation and less oliguria. Again, just bear with me because while these relative benefits of one medication over another does not mean that one is recommended. So I want to make sure that you follow until we get to the recommendation. A systematic review and meta-analysis of placebo, indomethacin, ibuprofen, and acetaminophen for closure of a hemodynamically significant PDA evaluated 68 randomized controlled trials of 4,802 infants comparing 14 different variations of indomethacin, ibuprofen, or acetaminophen. And the overall PDA closure rate was 67.4%, and a high dose of oral ibuprofen, like different than the course that I just mentioned earlier, 15 mg per kilo to 20 mg per kilo, followed by the doses of 7.5 to 10 mg per kilo Q24, was associated with higher odds of PDA closure compared with standard doses of IV ibuprofen or standard indomethacin. However, the high dose regimen has not been adequately evaluated in extremely preterm infant, as the sample size of such infant has been very limited and its efficacy and safety in this population is not known. A recent Cochrane review assessed the effectiveness and safety of early treatment, which is defined as treatment initiated by 7 days of age, or very early treatment initiated by 72 hours of age, compared to a more expectant management for a hemodynamically significant PDA. And I think that the timing of things is very important. So, what it found was that early or very early treatment did not decrease mortality and did not impact the rate of BPD, severe IVH, or NEC. Or surgical ligation while increasing exposure to NSAIDs. So the efficacy and safety of, and so then the next question that they're addressing is that what about repeat courses? And we know that sometimes we do a single course and then we have a patent PDA and so a patent ductus arteriosus, and we want to do another course. So the efficacy and safety of repeat courses of medication, if the initial courses fails to close the PDA, has not been adequately investigated in randomized controlled trials. And observational studies suggest that a second course may increase the closure rate, but a third course is less likely to do so, and that adverse effects are rare with additional courses. The evidence there is to be, there's no evidence to indicate that dual medication, like combining therapy, improves the rate of successful PDA closure or clinical outcomes. However, even though these medical therapies are frequently effective in closing the PDA, improvement in hospital and longer-term outcomes include all-cause mortality, BPD, NEC, or moderate to severe neurodevelopmental impairment have not been demonstrated. And so, although it's not truly clear, the authors say it's possible that some of the benefits in improved hemodynamics with a closed PDA may be balanced by the adverse effect of NSAIDs on the lung. So we'll get to they're presenting some more single center data after that, but obviously then the next step is expectant management. So what about not doing anything? And so with increasing concern of exposure to these medications without clear benefit, conservative, or also known as expectant management, is defined as the practice of just tolerating the presence of a PDA that does not appear to be hemodynamically significant and allowing a delayed spontaneous closure. And that has become quite a common approach. They mentioned a retrospective review of the CPQCC, the California Perinatal Quality Care Collaborative, that found that neonatal intensive care units reduced the use of COX inhibitors, was associated indeed with lower rates of BPD in infants weighing more than a kilo, but not so much in those weighing less than 715 grams, in whom there was an association of reduced use COX inhibitors with increased mortality. So there's similar retrospective multi-centered study done by the pediatrics clinical data warehouse. They have this big database that's been used in prior studies before at 259 NICUs that looked at close to 80,000 infants. And the between-year reduction in the NICU-specific proportion of treated with indomethacin or ibuprofen/ligation were associated with concurrent increase in local mortality, but with reduced PPD among babies that are weighing 400 to 749 grams, and decreased pulmonary hemorrhage in larger infants. In addition to that, there's a recent systematic review by Hunchid and colleagues, which we reviewed on the podcast. I think it was one of the impact articles of the year for the EBNEO impact article of the year campaign, that compared conservative management with any other treatment, either prophylactic, non-prophylactic, or even surgical therapy, in 12 cohorts and 4 RCT encompassing about 41,000 infants, 41,000 patients. 720 patients respectively. I'm sorry. It was noted that the cohort studies demonstrated a higher risk of mortality, but lower BPD and ROP with conservative management, while the meta-analysis of the RCTs did not reveal any significant differences between conservative and active treatment. So, to address the question prospectively, there have been some recent data that's been published. The PDA Tolerate trial is one of the most famous trials on this subject, and it looked at 202 preterm infants born before 28 weeks of gestation with a moderately to large PDA between 6 and 14 days of age, assigned to early routine treatment with either indomethacin, ibuprofen, or acetaminophen, or a conservative approach with an open label rescue treatment for those in either group with hemodynamically significant PDA. And although infants in the conservative management arm were more likely to receive the open label therapy, especially for those born before 26 weeks gestation, there was no significant differences noted on the primary outcome of ligation or the presence of a PDA at discharge. There's also no difference in any of the secondary outcomes of NEC, BPD, or BPD/death. Now, a trend for higher death was noted in the early routine therapy group. And in addition, among infants who were born after 26 weeks of gestation, those receiving early treatment took significantly longer to achieve full enteral feed and have had a significantly higher incidence of late onset sepsis and death, probably related to the fact that they might need longer invasive sort of catheters and so on and so forth. The other two trials that I think are mentioned in this review are the Ductus trial, which we've reviewed on the podcast before, looked at 273 infants born before 28 weeks with a large PDA to receive either expected management or early ibuprofen therapy, with the primary outcome of NEC, moderate severe BPD, and or death at 36 weeks. Open label was considered if the criteria was met for heart failure and clinically significant shunt. Now, the primary outcome occurred in 46% of the expectant group compared to 63% in the early ibuprofen group. No significant differences were found in that study on rates of NEC, death, and although there was an increase in BPD in the ibuprofen group. So again, not really favoring again the intervention opinion. Another study that's mentioned is the Baby Oscar trial, which evaluated early treatment with ibuprofen for a large PDA in extremely preterm infants 23 to 28 weeks, and randomly assigned 326 babies to receive ibuprofen and 327 to receive placebo. Death or moderate/severe BPD occurred in 69% of the ibuprofen group versus 63% in the placebo group, with death occurring in 13% of the ibuprofen group and 10% in the placebo group. Again, no reduction in death or BPD in these infants. So there's ongoing trials. And the conclusion of this particular review of the literature on the treatment for diagnosed PDA is that selective treatment of infants born at or before 28 weeks who are at high risk of a PDA may remain an option beyond 2 weeks of postnatal age, and deferral of early treatment in these infants without hemodynamic compromise may allow avoidance of treatment of those whom spontaneous closure occurs without compromising the potential efficacy of future medical treatment. Deferring early procedural closure in the PDA that is not hemodynamically significant may have similar advantages, avoiding a procedure in many infants in whom the ductus closes without treatment. The duration of such watchful expectancy needs to be determined, and more evidence is needed. And I think that's going to be something that we'll see with other articles later on, where this early treatment in the first 2 weeks is what we have a lot of data on. And it seems that we don't have enough data to suggest the intervention at that time, but that after 2 weeks, maybe there's room to recommend an intervention based on symptoms and hemodynamically significance. Then after that, obviously, the paper, I'm going to try to be a little, I think that this is the aspect of the paper that everybody really had questions about and wanted to review. So that's why I spent so much time. But obviously, after that, they talk about procedural closure and they talk about surgical closure. And obviously, it's a very effective, but it has so many risk factors: pneumothoraces, vocal cord paralysis, chylothorax, etc. And it's associated with increased BPD, ROP, and neurodevelopmental impairment. And it's usually reserved, right, for failed medical therapy. Now, they talk about this, the advent of transcatheter closure, that it's rapidly evolving and that it has a very high success rate, 95.5% in recently reported studies, and 99.4% at 6 months. And that the registry data shows that its success rate is extremely high. There's lower morbidity compared to surgical closure, but they're highlighting that there's still no randomized trial to actually assess that particular procedure. So I think it's kind of one of these things where there's so much promise, but yet not all the data that we would need to make a formal recommendation. The other thing that's very interesting in the paper is the mention of adjunct and other medical non-pharmacological therapy. And so I'm going to talk about these things, which basically all the things that we do for the PDA that are not directly treating the PDA, but like fluid restriction, for example. Um, and they mentioned how restricted water intake in preterm infant has been shown to increase postnatal weight loss and significantly reduce the risk of PDA and NEC, with tens for reduction in BPD and death. So there is some evidence that early fluid restriction may reduce the incidence of PDA. However, what the AAP mentions is that this evidence is based on trials that are from several decades ago and may not be so generalizable to current practices, and especially not generalizable to the type of immature patients we care for today that probably were not cared for back then. And so there is no evidence, according to the AP, that restriction is helpful following the diagnosis of hemodynamically significant. And fluid restriction after diagnosis negatively affects energy intake and growth. And a reduction of fluid intake from 145 to 108 ml per kilo per day did not change respiratory variables, did not change FiO2, did not change blood gas values, PDA diameters, blood flow velocity, and so on. Most of us might think that this kind of fluid restriction is kind of aggressive, but obviously that's what the data is available for. It may be optimal, they say, to limit fluid restriction to a minimum of 120 to 130 after the first week to limit such adverse effect of over-restrictive fluid intake. They then talk about diuresis and loop diuretics. And basically, what should be mentioned is that loop diuretics, such as furosemides, increased renal prostaglandin E2 production in vitro, causing PDA dilation in vivo in neonatal rats. So sometimes you're trying to do something good, but you're maybe affecting negatively the PDA. And that early prophylactic use of furosemide in small randomized trial led to more rapid postnatal weight loss and a higher heart rate, but with a trend towards a higher prevalence of PDA. Hence, there is a concern over the use of loop diuretics in PDA and lack consensus. Now, so I think I'm gonna leave it at that. Obviously, they talk about respiratory management, but I'm just gonna finish this very long review with the final recommendations from the AAP. So I'm gonna read straight from the recommendations for clinical practice, and maybe that's what we can clip if you wanna know what to take away. Number one, prophylactic medical interventions are not recommended at any age or birth weight for the purpose of reducing the risk of symptomatic PDA, and there are no effects on mortality, BPD, or neurodevelopmental impairment. Level of evidence is 1A. Number two, early fluid restriction may reduce the incidence of a PDA. However, like we just said, such data are from decades ago, may not be generalizable to current practices and patients. There is no evidence that fluid restriction is helpful following a diagnosis of a hemodynamically significant PDA. Level of the evidence is 2B. Furosemide may be helpful as an adjunct. Level of evidence is 2B. Ventilator management strategies have not been adequately studied for firm recommendation. Number three, very early, less than 72 hours of age, or early, between 7 to 14 days of age, routine treatment to induce PDA closure in preterm infants, either medically, via transcatheter, or surgically, is able to close the ductus, but does not improve outcomes and is therefore not recommended. So level of evidence is 1A. So this early, pre 2 weeks of life closure, not recommended. Conservative management in this age group may let infants avoid medical therapy, procedural exposure, allowing spontaneous delayed closure without risk of increased adverse outcomes. It is likely that the presence of a PDA is a marker for more extreme immaturity and a biomarker for worse outcome, but treatment to close the PDA may not significantly impact such outcomes. Three more recommendations. Number four, there are insufficient data for recommendations on management of infants with a hemodynamically significant PDA beyond 2 weeks of age. Benefits and risks of watchful expectancy with close monitoring, attempted medical closure, transcatheter closure, or surgical closure of the hemodynamically significant PDA have not been adequately defined, and the duration of watchful expectancy needs to be determined, and more evidence is needed to determine an optimal treatment strategy. Again, you are seeing that beyond 2 weeks, there's a lot more flexibility. The recommendations are much, much more loose, and it's not really making a commitment one way or another. And that's what leads us to recommendation number 5. It is considered reasonable to attempt pharmacologic closure of a hemodynamically significant PDA beyond 2 weeks of age. Ibuprofen as a preferred agent, although acetaminophen or indomethacin are acceptable alternative. Level of evidence 5. So when you review the level of evidence, that means that basically level 5 is like, it's just an expert consensus. Like, it's not based on strong data. So it's the lowest level of evidence possible for that particular recommendation. I know some people might say, oh, ibuprofen, whatever, but I'm just reading the recommendations. Finally, the last recommendation is that if the hemodynamically significant PDA persists beyond 2 weeks of age and despite pharmacologic therapy of up to 2 courses, such infants may be considered for either transcatheter or surgical closure. I'm going to leave it here. I've spoken for a long time, but it was a big paper. And yeah.
Yeah, and I think it's so important that everybody knows this is here. You definitely have to take a look at it, and go from there. That was very helpful. Thank you. What do you
Yeah.
think?
I think that it's a very controversial topic. You can
Yes.
see as you read through the paper that the AAP is like walking on eggshell, trying to
Sure.
make sure they don't make a recommendation that is ill-advised. And I think they do a very good job at reviewing all the evidence. And you can still see that it's controversial, but I think that they set the mark for this is what the standard of care should look like. And I think that what I'm taking away right now is that your PA will manifest itself probably in the first week of life, but you should not attempt to treat it, I think, until 2 weeks have elapsed. I think that's something that I'm taking home right away. It seems that there's not strong evidence to suggest one or the other in terms of medication, but that ibuprofen probably is the one that they're recommending. I still have a lot of reservation about ibuprofen, and considering the level of evidence, I might still favor acetaminophen if you ask me. And then all these adjunct therapy with Lasix and fluid restriction, I think that, again, we have to be very cautious not to be too aggressive. Not too much. If you want to use 1 or 2 doses of Lasix, maybe not to be too aggressive with that. And fluid restriction should be held at a minimum. I think I would say if you're capping your babies at 150, 145, you're probably okay. But I wouldn't start playing with much more fluid restriction than that. And that's it. And I think that they're highlighting that transcatheter closure has not been as tested as we would like. So just don't ship every kid for transcatheter closure if you don't have good reasons.
Phew, that was a great overview. Thank you. Well, then I'll give you a break. I know you still have
No, actually,
PDA
I don't want to.
papers, or you want to
I don't want to
carry
take.
on
Yeah, I just want to carry on quickly
since the
because
topic is the same.
since the topic is the
All
same,
right.
because obviously, one of the reasons why we wanted to focus on the PDA paper today, I'm going to try to find this other article that I printed. But basically, there was an article in JAMA Peds that was published recently looking at active treatment versus expectant management of patent ductus arteriosus in preterm infants, a meta-analysis. So it's interesting that as we're reviewing this evidence, this meta-analysis comes out a few weeks later. But surprisingly, it's not going to create controversy. I think it's aligning with what we just reviewed. And so they
Goodness.
thank God, they assessed basically the goal was to assess the clinical outcomes of active versus expectant management of hemodynamically significant PDA. Basically, the primary outcome was a composite of death at 36 weeks postmenstrual age or at discharge, or moderate to severe BPD. Death at 36 weeks and moderate to severe BPD. So, and they had some more secondary outcomes. This meta-analysis ended up including 10 randomized control trial involving about 2,000 infants and about 1,000 infants in the active treatment group and another 1,000 in the expectant management group. These were relatively quite immature population with a mean gestational age of 26 weeks, mean birth weight of 874 grams. And the incidence of the composite outcome of death at 36 weeks or at discharge or moderate to severe BPD was higher in the active treatment group versus the expectant management group. 56% versus 50%, p-value of 0.02. Death at 36 weeks were higher in the active treatment group, 14 versus 11%, and there was non-significant increase in moderate to severe BPD, 47.4% versus 43.3%, and also for PVL, 5.7 versus 3.5% in the active versus expectant management group. I'm going to let you guys review. Review this paper. Obviously, the intervention here was looking at the intervention in the first 2 weeks of life. And so that's why it leads the authors to conclude that this meta-analysis found that active treatment of a hemodynamically significant PDA during the first 2 weeks of life was associated with significantly higher incidence of death or moderate to severe BPD and with increased mortality compared with the expectant management approach. So kind of the same thing within the first 2 weeks, maybe back off. And because it's a meta-analysis, it sort of uses some of the similar data that the AP report used. And now I can get a break.
Are you sure?
I'm done.
Okay, well, I'm happy to carry on then. I'm actually going to do a little bit of a review paper myself. Um, it is in actually pediatric neurology, and this is a consensus approach for standardization of the timing of brain magnetic resonance imaging and classification of brain injury in neonates with neonatal encephalopathy, hypoxic ischemic encephalopathy, a Canadian perspective. So that's a mouthful, but this is on behalf of the Newborn Brain Health Working Group of the Canadian Neonatal Network. Many of the authors are intimately connected with the Newborn Brain Society, but this is they are trying to standardize their approach across Canada. So basically, the Newborn Brain Health Working Group of the Canadian Neonatal Network um, represents these 26 NICUs across Canada, which offer therapeutic hypothermia for babies with neonatal encephalopathy. So they created this task force. They had neonatologists, radiologists, neuroradiologists, pediatric neurologists across the centers to come and develop, again, these consensus guidelines using lit review and expert opinion. So the goals were really to develop a clinical classification of brain injury patterns. The second, to establish a standardized MRI protocol. The third, to adapt or modify existing scoring systems and to achieve consensus on the timing of the first brain MRI. So basically, this all started with a set of surveys. They've previously published this in pediatric research in 2023, looking at just the variation in care of neonates during therapeutic hypothermia across their network. So they had 24 out of 26 centers respond, and they did have some national guidelines at that time about um, who qualifies for therapeutic hypothermia. So, in general, the centers were following the national guidelines regarding the use of the modified Sarnot score to assess the severity of encephalopathy, the need to initiate therapeutic hypothermia within the first 6 hours, and the importance of follow up. But they recognized that the practices otherwise varied significantly: ventilation, definition or treatment of hypotension, echocardiography, sedation, EEG, MRIs, placental analysis, and follow up. So this is their ongoing work to create some standardizations. So basically, this is I agree, like you said with the other paper, this is an excellent review and overview of HIE and therapeutic hypothermia and how we evaluate it. And so basically, their recommendations are kind of in the main paper, so they review kind of the literature and then kind of give their recommendations. So I think it was very useful paper. So I'm going to start off with basically just standardizing the brain MRI protocols, and they indicate they recognize why this is a complicated issue. Different facilities have different access. But again, by standardizing the protocol, maybe everybody can get the same thing. Of course, a call to action is that optimally everyone would be read by a pediatric neuroradiologist. They recommend using specialized coils, so smaller, dedicated neonatal or pediatric brain coils, 12 to 15 centimeters, to improve image resolution and signal quality. Um, Adjusting the MRI parameters so we can get better data. So, longer times for the T2 weighted imaging, longer repetition times for T1 weighted imaging. The field strength, so a 3 Tesla MRI provides higher resolution, but excellent results are achievable, they say, on 1.5 T MRI with the proper settings. So, what are the MRI sequences? So, definitely the inclusion of T1 and T2 weighted images to look at the structure, the anatomy, DWI, diffusion weighted imaging, to detect ischemic injury, a gradient echo T2 or susceptibility weighted imaging to identify hemorrhages and microbleeds. And the fourth, a 3D T1 weighted images preferred for detailed anatomy, although high quality 2D T1 images would be acceptable. Then they go on to talk about magnetic resonance spectroscopy, or MRS, a valuable tool for evaluating brain metabolism. And so we know that babies who are born with asphyxia, they have this elevated lactate to creatinine ratios, and they have reduced NAA levels in the basal ganglia, which are strong indicators of poor neurologic outcomes long term. So, this may help us predict prognosis, but this is confusing in neonates because even healthy neonates may have low NAA levels. And um, even in normal neonates, especially the preterm infants, they may have moderate amounts of lactate. So, those may they provide conflicting information. And then timing of MRI, and I think this is a big one. I think we're all continually discussing it. And so I'm going to kind of read this one in full. Most centers across Canada are performing their brain MRIs in neonates within the first week of life. A few NICUs practice the MRI timing recommended by the task force. One center performed one first MRI on day 4 of life and repeated again on day 15. Another center systematically performed MRI around day 10. And early MRIs, like during therapeutic hypothermia, for research or for discussions with the families regarding withdrawal of care. Two centers did not use a standardized day between days 4 and 10 of life to perform MRIs. So, after this prolonged discussion, the task force agreed upon recommending performing brain MRIs in neonates consistently, either on day 3 to 5 of birth, so right after cooling, or on days 10 to 14 of birth, should the baby still be admitted to the NICU. And they further elucidated that near the end of the paper, um, where they wanted to reflect this literature, but really suggest performing this brain MRI on day 3 to 5 of life, and recommending the repeat of the MRI on days 10 to 14 when that first MRI is not totally consistent with the baby's clinical picture in either direction. So, if things are worse than you anticipate, or especially if things are better on the MRI than you anticipate given the baby's clinical picture. Um, so, subsequent to timing of MRI, they wanted to provide a more robust radiologic classification regarding the patterns of brain injury. Now, this is a really long section, so I'm not going to read the whole thing, but I think that anybody who is new to learning about HIE or therapeutic hypothermia should definitely take a look at it. It gives a really good explanation about what's most common, why you get different presentations. So I thought that was really useful. And they also included some other findings like um, intracranial hemorrhage, cerebellar injury, and brainstem injury, things we don't always tend to include. And then they wanted to look at the available literature for MRI scoring systems. Again, a wonderful review on all of the available scoring systems. And then in the end, their working group chose to use the modified Wiki score combined with the Wisnowski classification for their database. Now, they also kept the Barkovich scoring, which a lot of people were using in the early studies because so many centers have been using it. So they do also here list their, let's see, 3 major modifications to the combo scoring system. So that way they can score babies in a more standardized way, describe their injury in a more standardized way, to be able to compare across centers. Um, so I thought that was really interesting. I thought people should take a look. Um, and I think we're all still always debating when it's the right time, but I think this gives us a little bit more guidance. Um, thoughts?
No, I think this is almost like a book chapter. It has so
That's
much
right.
information, and then these sections are very well
Beautiful
crafted.
pictures also.
Yeah, there's lots of pictures, which is
Mhm.
good because, like, if you wanna see what certain things look on
Mhm.
MRI, there's these pictures there, and each of the sections, like, it's a long paper, but it's broken down, so, each section is not very long, and I think that the one that everybody really wants to,
Yeah,
debate is probably gonna be
the
the timing
timing.
of the MRI, um, and yeah, I don't know what your thoughts are on that in terms of what you think is the most practical and, like, hearing the Canadian sort of practice model, like, what do you think?
Yeah, no, I mean, I think it's consistent with the data that we have regarding the changing um features of MRI findings, and they do discuss this, and many other papers discuss this. Again, early on, you may rely more on the diffusion weighted and the MR spectroscopy. Later on, more changes on the T1, T2. I think a good take home message, regardless, as we're discussing this, we're all trying to find what is the optimal time that will give us, so what are we looking for? We're trying to find the optimal time that will give us the best prognostic information, right? So what is this baby going to look like as a child? But several studies have shown pretty good agreement between early and late MRI scans. So again, that's in a huge population of babies, big meta-analyses. Is it different for individual babies? Yeah, I think so, especially depending on their type of injury. And again, potentially what was their, preceding event. Um, but I think in the States, I mean, major institutions have pretty much adopted this same kind of timing situation. I think especially it's nice to get the early MRI because some of our babies are ready to go home before day 10 to
Yeah.
14. So it's nice to have that information. But I think especially that guidance that, like, even if the MRI looks great, but the baby doesn't look great, then definitely an indication to follow up the imaging
Yeah.
and make sure that we haven't missed anything.
Yeah.
I
Very
also
interesting.
yeah, I did want to also highlight there, in pediatric research, there was another review, which I'm not gonna get into all the details, but I think, it's valuable. It's entitled "Shifting Outlooks After Neonatal Encephalopathy in the Era of Therapeutic Hypothermia." Um, and I think, especially as we talk about MRIs that are better than we anticipate, or we're all really thrilled that the MRIs look normal. Just a reminder that, and I'll read this: children with a history of HIE face challenges in motor skills, emotional regulation, behavior, language, communication, cognition, learning, and academic achievement. All children with a history of HIE can benefit from close neurodevelopmental surveillance, even when the brain MRI is reassuring. So it's a beautiful review about kind of long-term outcomes, but I want to share this impact statement. So children with a history of moderate to severe hypoxic ischemic encephalopathy without evidence of significant brain injury on post-cooling neonatal MRI are still at risk for a range of neurodevelopmental challenges at school age and beyond. Neonatal neuroimaging and early neurodevelopmental evaluations do not reliably indicate outcomes at school age, making early prognostication and counseling families in the NICU period and during neonatal follow-up clinics challenging. So all children with perinatal HIE, regardless of MRI findings, should have long-term follow-up after discharge and support through school age. So I
Yeah.
think
I
that's a good
mean, I
reminder.
agree, but I also wanna moderate that statement a little bit, I think.
Okay, let's hear
Uh,
it.
Me, the expert. No, what I want to say is I agree with the statement. Obviously, I think that because you have a sort of good looking MRI, it doesn't mean that like, oh my god, that's it, we're
Yeah.
good, like it's all behind us. But on the other hand, I think that we should not also overlook sometimes positive test results. And for
Sure.
families, I think it's very important that, yeah, that's true. I mean, I know that a negative MRI doesn't mean that there's not going to be anything, but it's definitely better than a terrible looking MRI.
Mhm.
Um, and so I think that I just want to make sure that as we keep that in mind, we don't also lose sight, because then our tone and our conversation with family can become so negative, because it's like
Yeah.
the bad thing happened and we are doing this quite invasive procedure, and then you're going to get an MRI. Oh, it's normal, but it's still not, doesn't mean anything. It's like, no, I think let's make sure that at least we keep giving parents the right guidance, all the while celebrating the small successes that we can celebrate along the way. um
Yeah, and I mean, I totally agree with you. I
I
mean,
knew
right.
I was not going to say that something too controversial, so I'm
I
okay.
totally agree with you. I think it's part of that balancing hope and making sure
Yeah,
that kids don't fall through the cracks. So,
yeah.
yeah, saying we're thrilled that this looks great and why we want to hook you up with kind of early intervention. I think another reason why connecting families to say organizations like Hope for HIE is also very valuable because they can connect with other parents, other resources, and they may not recognize that they need the resources until they need them, and that may be years after they see
Mm,
us. I know
yeah.
Betsy has so many stories about that, so
And we have to, and I remember, I know we're kind of egotistic as neonatologists, because it's like we look at our own little backyard and it's like
mhm,
it's true. If we can have a baby, do a good resuscitation, go through cooling, get a normal MRI, we feel like
we're
we did
thrilled.
pretty good.
Yeah, that's right.
And it's true, because that's the extent of our sort of oversight of the baby. But so I think that we just have to mitigate, make sure that our optimism is well conveyed. All right, we're almost way over time, and it's like so I wanted to mention there's one article that I cannot not mention today. It's published in the Archives of Disease in Childhood, and it's called "Treatment of Hypotension of Prematurity: A Randomized Trial." First author is Thomas Alderleeston. It's a very interesting paper. So we all know that hypotension in preterm infants is common, but the management remains controversial. We've been talking about that on the podcast many times. Now, the traditional approach uses a simple rule that when the mean arterial pressure in millimeters of mercury falls below the infant's gestational age in weeks, that's hypotension. And so for a 26-week infant, we would intervene if the MAP dropped below 26 millimeters of mercury. Now, the evidence supporting this approach obviously is not as solid as we might think. The literature remains inconclusive about whether low blood pressure directly contributes to brain injury in that sort of measurement. And some studies suggest an association between the lowest mean arterial pressure in the first 24 hours and short-term outcomes, while others question whether treatment actually helps. Now, recent work has suggested that a low mean arterial pressure alone might not be the problem, and instead is this just a reflection of a more comprehensive issue with the whole patient involving low cerebral oxygenation, that maybe that portion of the syndrome of hypotension is associated with worse neurodevelopmental outcomes. And this is what basically is the foundation of this trial called the TOHOP trial, the treatment of hypotension of prematurity. Um, and The hypothesis for them is that if you have a more perfusion based approach, something that they're coining as permissive hypotension, which raises my blood pressure alone, like we'd never want to be permissive with hypotension, but
Watchful waiting of the
watchful
hypertension.
waiting, I like permissive hypotension. It's like saying acceptable death. It's like it's not acceptable.
Well, we use permissive hypercapnia, don't
Yeah,
we?
it
We
feels
like
like
that
CO2
one.
is less nasty than
I don't know.
hypotension. In any
That's what
case,
they're trying to
uh,
show us here.
yeah. And they say that it might be safe as the standard treatment while reducing unnecessary inotrope use. So, this was a single center study. It was a randomized control trial conducted at the Wilhelmina Children's Hospital in Utrecht in the Netherlands between 2011 and 2018. They included patients who were born between 24 and 29 and 6 weeks with idiopathic arterial hypotension, basically defined as a MAP below their gestational age. They excluded babies who had um, if they had any concerns for major congenital anomalies, hypotension within the first like 72 hours of birth, if they had no A line, if there were any signs, any overt signs of sepsis, they mentioned, and so on. But so randomization and intervention. So when the infants met the hypotension criteria, the map below the gestational age, for at least 15 minutes, they were then randomized to two groups. The standard treatment group, which followed traditional approach, you treat based on the map, based on the number of the mean arterial pressure. I'll talk to you a little bit about what their approach was when it comes to that. Or you were sent to the permissive hypotension group, which used a more nuanced approach. So what does that mean? So number one, they would check your regional cerebral oxygen saturation. And in order to meet the criteria for hypotension, you would have to have a regional cerebral oxygen saturation of less than 50% for 30 minutes. You had to have also low urine production of less than 0.6 ml per kilo per hour. Your cap refill had to be greater than 3 seconds on 2 consecutive measurements. You had to have a lactate of 6 or more, or a mean arterial pressure that was 5 millimeters of mercury below the gestational age, meaning like that was sort of their safety net. Because you only had to get one of these criteria in addition to the map dropping to meet the criteria for being hypotensive. And in the end, basically, it doesn't really matter what any of these parameters said. If your map was like 5 points below your gestational age, then you were considered to have true hypotension. In terms of the approach to treatment of hypotension, their approach is number one, fluid bolus, number two, dopamine, number three, dobutamine, and then epinephrine, potentially addition of hydrocortisone plus minus. I'm not going to get into this. This is a single center study. If you want to send hate mail to the dopamine, second line dopamine, like, no, they're
No,
sharing.
don't do that. Just
Don't do
know
that.
that dopamine is
Yeah.
becoming less favored.
The outcomes is neurodevelopmental assessment at 24 months corrected age using the Bailey scales. And they had key secondary outcomes that included all-cause mortality, a composite outcome of the Bailey scores, and the occurrence of IVH in the first 7 days. So we're running late, and I'm going to go into some of the results. They enrolled 86 infants, which importantly is only 57% of their projected enrollment due to, number one, recruitment challenge that we'll discuss a bit later. The median age at randomization is about 5 hours after birth. And in terms of the primary outcome, the key findings were that there was no significant difference in neurodevelopmental outcomes between the groups. The cognitive index scores were 90.9 in the standard treatment group versus 91.7 in the permissive hypotension group. The motor index scores showed a similar pattern with 90.4 versus 94.1 for the standard treatment group and the permissive hypotension group, respectively. And when it comes to secondary outcomes, I think that this is where things get interesting. Mortality rates were comparable as well, 7.5% in the standard treatment group versus 13% in the permissive hypotension group. And the composite adverse outcomes of death or significant neurodevelopmental impairment, 54% versus 44% in the permissive hypotension group. Now, in terms of blood pressure management, and I think that this is where it gets really interesting, despite the different treatment threshold, the actual blood pressures achieved were remarkably similar between the two groups. The permissive hypotension group spent only slightly more time with MAPs below their gestational age, 11% versus 7.7% in the first 24 hours. But, and this is crucial, the permissive hypotension group led to significantly less inotrope use. Only 15% of infants in the permissive hypotension group received inotropes compared to 43% in the standard treatment group. When inotropes were used, the duration was also shorter, a mean duration of 17 hours versus 48 hours. In terms of cerebral oxygenation, the permissive hypotension group did spend more time with cerebral oxygen saturation below 50%, particularly in the 36 to 42 hour period and over the full 72-hour period. However, there was no difference in time spent below 55%, and importantly, no group effect could be demonstrated in the mixed model analysis. In terms of clinical events, 4 infants in the permissive hypotension group developed severe to late onset sepsis after the initial 72-hour intervention period compared to none in the standard treatment group. These infants were then treated for these particular instances, and the timing of severe IVH was similar between the group. Again, usually between day 3 and 4 of life. In terms of IVH, in terms of grade 3 or more, the rates were 7.5% versus 13% in the permissive hypotension group. So what's interesting is that the authors are showing that if you're less strict with the blood pressure, it might be feasible and you might have much less inotrope use without major adverse effects. One of the things that was interesting, as I mentioned earlier, is that they never really reached the recruitment, and the study was quite underpowered, achieving only 57% of projected enrollment. And they're saying that multiple factors contributed to this. Number one, the declining incidence of hypotension in their unit, but also a spillover effect where the staff began favoring the more personalized approach even outside the study, and most significantly, challenges with the consent process as well. So I thought this is interesting. The authors in the conclusion state that a more individualized and less strict BP-driven strategy for low BP and premature infants with a gestational age of less than 30 weeks and no signs of sepsis during the first 3 days after birth leads to lower usage of inotrope while maintaining similar BP levels and without signs of impaired systemic perfusion. Although the study is underpowered, they say they did not see any major negative effects of an individualized approach in terms of risk of death, neck, grade 3 IVH slash periventricular hemorrhage, or neurodevelopmental outcomes at 2 years. I thought it's interesting. It's an interesting study because some of these sort of shorter outcomes can give you like a little bit of of pause, but the change is not that significant. And I kind of like this idea of an individualized approach. I don't know if the data is there yet to roll this out and make it so much generalizable, but I thought this was interesting.
Yeah, I think it's complicated by the fact that not everybody we don't we not everybody believes we should be using gestational age, right? So might those babies that you allowed a permissive hypotension with another set of criteria fall into the same group, right? Like maybe they're not so different. Um, Especially we reviewed what just a few weeks ago, these beautiful graphs about blood pressure uh like ranges,
Yeah.
of babies, which I think challenge the use of the gestational age criteria. Not at every gestational age, but some especially so. And then what is the right antihypertensive? I mean, the right agent for helping with blood pressure? That's to debate. So I think those are the complicating factors with this study. But I think it shows that, again, the individualized approach and taking a look at the baby and understanding perfusion, things like that help us, make those decisions
Yeah, and
about
right away it makes more
treatment.
physiologic sense,
Yeah,
but I thought this was an interesting paper.
for
I
sure.
don't know if it has tons of practical implications, but I think it makes us think about blood pressure and makes us think about just looking beyond that number.
Yeah, and reminding us, right, to go back to the bedside. And so many of our clinical that's why they teach us it's not just for adults, all those markers of the different types of shock, we can see them in babies and they help us make decisions. Of course, point of care ultrasound and hemodynamic echo will be a supporting feature, but we can see a lot of those findings
But
on a clinical exam,
for sure, and especially when you have arterial lines, I think that one
right?
of the things to me, one of the things I'm taking away is that it's very variable. Like you
Mhm,
come by the bedside and it's like, oh, the blood pressure is now 23, and it's like,
mhm,
ugh. And then you come back, it's like, oh, it actually bumped up a little bit more now. It's 26, right? The mean
mhm.
arterial pressure, and you're like, okay, what do I
Great.
do? But maybe, and then maybe those are the instances where it says, okay, let's put nears, let's put something on the head, and let's look at the cerebral oxygenation, and then let's try to think a little bit more proactively about perfusion status. I think that's very helpful.
Yeah, and I think to your point, like, even if we agreed on what numbers to start medications and what medications to start, then, like, what are the right numbers to wean medication?
For
Like, what are the
for
parameters?
sure. And then like maybe the map is good, but like you see your diastolic is sort
Yeah.
of going down slowly, and you're like, well, technically the map is still equal or
Right.
above the gestational age, but like what else is happening?
That's
All
right.
these things really are the aspect of care that get me
For
excited because
sure.
it's more intelligent in my opinion.
And I think we've been talking about this in our unit that,
Yeah.
um, what is hypotensive for one baby, even at the same gestational age, may not be hypotensive for another baby.
Mhm.
And when you're like, "This blood pressure is low for this baby," and everybody's like, "The blood pressure is fine," and you're like, "But I know this baby, and this is not right for this
Yeah,
baby." I think, again, being at the bedside, continuity of care helps us make those decisions for kids. Very cool.
for sure.
Well, I have some more papers, but I just don't know that we have
Yeah,
time
same
today.
for me, but I think we overstayed our time, huh?
I think so.
All right. I guess we're going to wrap up. Everybody, thank you for staying with us today. Again, remember to fill out the survey and enter the giveaway, and check out the website for tickets to the Delphi conference this coming January 26, 26, 27, 28, 2026 in Fort Lauderdale. It was a pleasure doing Journal Club today, Daphna. I'll
Always.
see you next time.
Bye.